Welcome everyone to the online Shoulder and Elbow School. I'm Valentina Greco and I'm part of the junior committee. I would like to thank all of you for joining us today. The topic for today's session will be massive irreparable cuff tear in young patients, and we are honored to have with us Dr. Paolo Paladini from Italy, who has kindly accepted to share some of his cases, and Dr. Barth from France, who will discuss the cases. I would also like to introduce the 5 young surgeons we selected for today. George Avram from Romania, Ceyhun Çağlar from Turkey, Roberto de Giovanni from Italy, Edna Skopljak from Slovenia, and Susanna Pagnotta from Italy. If you have any questions, please feel free to write them in the chat and we will do our best to address them to the mentors at the end of each case. Let's get started.
Thank you, Valentina. Thank you for your great introduction, and thank you for this great opportunity to share our knowledge with Johan about the massive cuff. Of course, this is a very challenging topic because it's so difficult to have a good decision when you have a young patient with a massive irreparable rotator cuff tear. We can share some cases so you can understand, so you can give your opinion about this, and we can understand how to move and how to have good results with this patient. Okay, let's start. The first patient is a patient of 55 years old. I think we missed one. Yes, he fall in at home with 2 months before. Since the trauma, he has pain day and night, inability to perform even light daily living activities, and is under therapy with drugs for the pain. As you can see from the ultrasound examination, we have a supraspinatus tear in this patient. I think that we have to. There is some problem with the slides. You can see this is the clinical examination of the patient. The forward flexion is under the horizontal, under 90 degrees, the same for the lateral elevation. External rotation with the hand behind the head and the elbow forward, and the internal rotation to the buttock. You can understand that this is really a poor shoulder, and the constant score is 14. As you can understand, with this kind of test, we have a job test 3+, PAT test 3+, lift-off test +2, belly press test +2, and external lag sign negative and belly off sign negative. So, which kind of lesion do you expect for this patient? Johan, you cannot answer to this, you know. Susanna.
But can I give a... sorry.
Yes, please.
Yes.
Before we talk about the lesion, is there something that could miss in the clinical exam? And I have the question maybe for George. What would you like to know about the clinical exam? What do you would like to ask immediately after 2 months ago in a very painful shoulder? What would you ask for Paolo? George?
Well, I think that I would like to know if he has any comorbidities, if he's taking any medication, or if he's a smoker, for example. What is his line of work, and if he has an active lifestyle, and if he has any expectations, like how high are his expectations, for example.
Okay.
Yes, does this information change your procedure? If you know that the patient is diabetic,
yeah,
I don't think that this change your clinical approach. Maybe when you have to decide your decision making about the treatment, you have some different choice between a diabetic smoker patient respect to a non-diabetic.
Yes. And yes, I would just be concerned about the healing. Yes.
Yes, about the healing, but not about the diagnosis, I think. What do you think, Joan?
Yes, I totally with you. there is something very important about the clinical exam. That all the parameters that you have asked, George, I agree it's important. But immediately to treat this patient, one thing is very important about the clinical exam. What is it? Susanna, maybe.
The passive range of motion, probably.
Exactly. Very good. And how do you assess passive range of motion?
Can do an injection of lidocaine and check the...
No. Before just how do you evaluate the passive range of motion in your clinical practice?
We ask the patient to completely relax, and we move the arm with the patient trying to relax as much as possible. Because it's important to check if it is a pseudo-paresis or paralysis, or if the patient is stiff just due to pain, or if it's actually a proper stiffness.
As Joan told, it's really important to visit the patient maybe lying on a bed,
exactly,
to have the possibility to move in passive way the arm, and to avoid, because there is the problem of the gravity is really important. When you have a patient that is not able to lift the arm over 90 degrees, you should evaluate the patient from lying on the bed. This is really important.
And also to block the scapula.
To stabilize the scapula, yes.
Yes. So I think I'm very happy that you agree with this way to examine the patient, Paolo, because this is what I try to tell to all my fellows. I want them to systematically evaluate the patient lying on the table position, on the lying position on the table, because this way it's gonna be a reliable way to evaluate all the range of motion. And what kind of range of motion are you going to look for? Maybe Roberto?
Yes, first of all, forward elevation, looking for a non-stiff shoulder. It would be probably also useful to ask the patient if he had any prior shoulder pain, because a simple trauma, it's unlikely to disrupt the entirety of the cuff. A stiff and painful shoulder prior.
Excuse me to interrupt you, Roberto, but let's stay on the clinical exam. For me, we don't have to evaluate everything, but I think at least 3 amplitudes, such as forward elevation, external rotation at the side is important. Okay, and maybe internal rotation to the back. And this way you have the minimum that you can evaluate. Of course, you can evaluate the other range of motion, but this is an external rotation is very important to evaluate arm at the side in the lying position. So maybe we can ask now, Paolo, if the patient was stiff or not, because in his clinical exam we have some range of motion.
Okay,
so
you miss this information, but the patient is not stiff.
Okay.
The patient has a passive complete range of motion. And my question first was, what do you expect from this patient? Edna, we have a job test 3+, PAT test 3+, lift-off test 2+, with a belly press test 2+. What do you think?
What do you mean? What do we expect?
Which kind of lesion? Supraspinatus, infraspinatus, subscapularis?
Supraspinatus.
Only. If you have a PAT test positive 3+, I think that we have to understand if the infraspinatus is good or not. And with the belly press test, you can evaluate the subscapularis. So I think that we are in front of a very, very complex case in this patient, because we have all the tests practically positive, with just a couple of negative tests that are external lag sign, negative, and belly off sign. Negative, when you have an external lag sign, usually you have a complete tear of the supraspinatus, infraspinatus, and even teres minor. In this case, this is negative. So this is the only good chance that we have. Will you do some different tests, Joan?
No, I think you have done the main important test, so it's for me it's very good. So I would for sure we can expect a larger lesion than it was showed on the ultrasound.
Okay, let's go further. We can see the next slide, and this is the X-ray. Ceyhun, let me check. What do you think looking at this X-ray?
Yes, sir. Of course, sir. First of all, there is no glenohumeral osteoarthritis in this X-rays. I think it's good for us. And after that, there is no humeral head migration.
How do you assess that, Ceyhun?
I think everything is normal.
Quite normal.
Ceyhun,
I
I
think
have a
that
question for
if
you.
you look sorry.
Actually, this is a traumatic patient, and there is no glenohumeral osteoarthritis according to Hamada classification.
But if you look in
Yes.
the first X-ray on the left, you can see that there is a double sign in the inferior part of the humerus. So this is a sentinel osteophyte. This can show you that there is some degenerative arthritis, not so much, but there is something. And if you look, if you look at the X-ray, the second one, you can see that there is inferiorly under the acromion, you can find that there is a spur. These are all, this one is an indirect sign of calf tear. And you can see that the acromial spur, the anterior acromial spur is well visible in the outlet view on the right side of the slide. So I think that we are speaking about something that is not so young, maybe something that is very old as a tear. If you look well in the second slide, you can even see where is the bursa, but because there is a line on the left side of the central X-ray that is delineating the limit, the age, the lateral age of the bursa that is very, very full. Do you see something else, Joan?
Yes, I want to emphasize something because you explained it very well. Can we go back to the X-rays, please?
Yes.
I want to tell you one thing. So I agree with you. There are some signs of degenerative change, but not too much. And
Not
the
too
main
much.
sign is the acromiohumeral distance, okay? If you want to see, so basically you suspect a massive rotator cuff tear, and on the X-ray, you have already signs if you can probably repair it or not before you will ask the rest of the imaging that we suddenly say, but even in the X-ray, you can have a very good information on that, and it's based on the acromiohumeral distance. Don't look at the homoscapular contour, which is not reliable, but the acromiohumeral distance is a very important parameter. And if it's greater than 6 millimeter, you have a chance to find a reparable cuff. However, if it's below 6 millimeter, there is a high risk that you might have a chronic cuff problem where you might probably have some fat infiltration. So there is a high correlation. Sometimes when it's traumatic, you can have a reduced acromiohumeral distance, but it's an important sign that you must emphasize, I think.
Thank
You
you,
agree,
Joan.
Paolo?
Really good observation. This is a famous paper that was made by Novejos Rand in the first 2000. I remember this. Let's go. Which is the next examination, Roberto?
Definitely
What we do?
MRI. Definitely
MRI. Okay, right. This is MRI. Axial view. And the coronal view.
Okay,
Disaster.
would you go in?
We can see again. Okay. Roberto,
Yes,
what about the left?
we see a full thickness.
I can stop.
Thank you. This is a tissue-weighted image. We see a full thickness tear of the subscapularis, some dishomogeneity, hypotensity in the infraspinatus, in the posterior cuff, which I would like to see better, but there's definitely something going on in the anterior cuff that's not going good. Would you go more cranial to in the left image?
Oh, sorry.
Yeah, probably posterior cuff. I'm not quite sure about the insertion, but there's some hyperdensity I would like to evaluate better. While since we can't see here about anything about fat infiltration or not, we might as well move to the coronal side on the right side image.
Okay.
Thank you very much. Okay, subscap.
Okay, it's really important when you look at the coronal view to understand where is the subscapularis. You can see here the subscapular, you can see here the coracoid, and you can see here the subscapularis that is well present in the inferior part. When you go medial, when you go posteriorly, you can see a lot of fluid. So you have just the inferior part of the subscapularis. Going back, going posteriorly, you can see that there is a complete tear with the very huge retraction of the supraspinatus with a lot of fluid in the bicipital groove. And posteriorly, you can see that the infraspinatus do not seems too degenerated. Is still black, like the
in terms of muscle belly.
Yes, the muscle belly is not so good. It's not so bad. Interesting. Edna, do you have some suggestion for the treatment for this patient?
I think that the treatment depends on the patient's expectations. Like, I don't know, is it like suitable for the patient to do a reconstruction?
Okay. Susanna, do you think that this kind of cuff lesion is repairable or not?
So first of all, I would like to see a parasagittal view just to check better the trophism of the cuff and the fat infiltration.
Okay, right answer. This is the...
Okay, so we have a massive tear of the supraspinatus. It doesn't arrive to the Y.
On the right side, you can see that there is a complete resorption of the supraspinatus.
So normally we would love to see the parasagittal view with the Y shaped. So
okay, we cannot have. We don't know. Not have.
So from what I can see, I think we have fat infiltration of the supraspinatus. So probably it's a cuff wear, so it's an old lesion. But with the recent trauma, he fell and he ruptured the infraspinatus and the subscap probably. So I would actually try a cuff repair in order to at least repair the infraspinatus and the subscapularis. So try to restore some balance. And in the previous slide, I was seeing anterior subluxation of the biceps. So I would do a biceps stenotomy.
Okay. George, what's your idea?
Yes, given the patient's age, I will also attempt an arthroscopic repair with a double layer infraspinatus repair. I will also attempt the subscapularis repair, a biceps stenotomy, an AC joint resection, and also I don't think so. After the infra and subscapularis repair, I would still probably try to release a bit of the supraspinatus and see if it's even possible to do a medialized repair. If not, most probably I would think about the superior capsular reconstruction.
Superior capsular reconstruction.
But if the subscapularis is not repairable, then probably it won't work.
Okay.
So maybe we should also think about the tendon transfer if the subscapularis is not repairable.
Okay. Joan, do you have any question about the just the examination, the MRI, or?
Yeah, it's difficult for me to evaluate the fat infiltration. I have the feeling that the infra is okay.
It seems okay.
But
Yes.
maybe yes, infra is okay. Subscap is fat. Is that right?
Yes.
So it looks like an old subscap. So basically, it looks like a old subscap tear, maybe.
It seems an anterosuperior tear, no?
Yes, but you know, to have such a fatty infiltration stage on the subscap 2 months after a fall, it's hard to believe it's related to the fall. You
Yes.
understand what I mean?
I
So-
think the same. I think that the most important thing that you have to look on this MRI is that there is probably nothing new in this patient. So all the lesions that you are observing are all lesions that are, I think, not related to the trauma of a couple of months ago. So maybe this patient is already a patient with a calf tear, an old calf tear, that has some trauma that changed the equilibrium of this shoulder.
Sure.
So I think that we should evaluate well this kind of problem in this patient, because if you look the MRI, if you look the other MRI, if you look at the X-ray, it doesn't seem a young patient, no? I'm 56 years old, so this patient is 1 year younger than me. But I think that if I do X-ray, I have different X-ray from this patient. Less degenerative changes, less degenerative changing of the acromion. So the question is, this is the principal, the main findings. The question is what to do with this patient. We have a complete tear of the supraspinatus, upper half of the subscapularis, complete tear of the infraspinatus, maybe, almost, and muscle atrophy. So we have these choices. You cannot. George was fantastic because he told all the possibilities that we have, but we need one. We cannot make to the patient sign all the consensus for all the operation, from the calf repair, the partial calf repair to the reverse prosthesis. So what's your first choice for this patient, Ceyhun?
I think my first choice is this patient is muscle transfers.
Muscle transfer.
Yes.
Okay, but we have.
Why do you want? Wait, Paolo.
Yes.
It's not. You must tell why you want to do a muscle transfer.
Yes.
What do you have in the head when you say I do a muscle transfer? Why do you use that argument?
First of all, because the patient has muscle atrophy and some fatty infiltration. When we, of course, first we should repair the rotator cuff, especially infraspinatus and subscapularis for force couples. But after the repair, the cuff maybe retear. I think this 55 years old man is active patient. I think tendon transfer works so good for this patient. I think it's he will be satisfied.
To do a tendon transfer, we need one important thing, that we miss some function.
For example, he should have 60 60 degrees of forward flexion.
Yes, but the patient has the patient has no drop arm sign on the external rotation, never in internal rotation. So the patient has not missed any function. External rotation, internal rotation are still preserved. So I think that in case like this, it's not maybe a tendon graft can be a muscle transfer can be the future for this patient. But at the moment, the patient has not missing any function. Do you think this, Joan?
Completely. For me, it is important to understand the role of a muscle transfer. Role of a muscle transfer is for a pseudoparetic shoulder or with a lag sign, but not for a pseudoparalytic shoulder like this, especially if you can maybe repair something to restore the function. But I totally agree. For me, it's not the indication for a transfer, because and which transfer would you do, Ceyhun? What was your idea?
Maybe a lower trap transfer.
But
Lower
why?
trap.
Because maybe
Because it
look,
works. It works
Ceyhun,
similar to infraspinatus.
Yeah, but you have a reparable infraspinatus. You have a reparable infraspinatus. So why not trying to repair?
If I can repair the infraspinatus, of course, I should repair it first of all.
So first, okay, Susanna, what's your idea about this?
I'm not 100% sure about the muscle atrophy. So in my mind, I still think that at least one of the muscle was a recent rupture. So in the acute setting, I will try to repair what's repairable. So probably I won't even try to repair the supraspinatus because it looked really retracted and infiltrated, so it can only give stiffness to the patient. But I will try to repair the subscap and the infraspinatus to try to restore the balance. And I will do the tenotomy of the biceps, which I think now is the main reason for pain for the patient.
Okay, let's see what we can do for this patient. We can do a latissimus dorsi transfer, pectoralis minor, pectoralis major, latissimus dorsi and pectoralis, and latissimus dorsi and pectoralis major. Because we need to understand which is the function that we miss. If we have a missing of the external rotation, we can trust on latissimus dorsi, we can trust on lower trapezius, but we have to substitute the function of the external rotator. If we have a missing of the internal rotation, we need some transfer for the anterior part of the calf, so latissimus dorsi, even for subscapularis or pectoralis minor or pectoralis major. That are all three proposed the operation for the calf, for anterior part of the calf. So I think, but the problem is that we have some problem. Which are the lesions that are more prone to have a pseudoparalysis of the shoulder? Joan will know this paper, and I think that even you understand well, know well this paper. We know that if the subscapularis is involved, you have a lot of the possibility to have the pseudoparalysis of the shoulder. So I think that the main problem in this patient can be the presence of this tear of the subscapularis. The subscapularis is as a vector that you cannot have other muscle doing this. Roberto, what do you think with this information? Will you change your idea, or will you start for arthroscopy?
No, 100%. I mean, the main point here is to assess if it's repairable or not. We always talk about massive and repairability, massive and repairable calf tears. And to assess if this subscapularis is repairable or not, preoperatively with this examination, I find it quite difficult because it didn't have positive lift-off, it didn't have frank examination for complete insufficiency of the subscapularis.
Yes, but
Beyond-
this paper showed us that passing from a complete tear to the subscapularis to a tear of the superior part of the subscapularis, you have a huge opportunity to recover the forward flexion.
So I definitely would repair what's repairable. That's the point.
First of all, try to repair all it's irreparable. Also, you can repair. George, you still maintain your idea to do all the possible, or just do the minus you want? You can.
So not everything that's possible, but definitely try to repair the subscapularis. If the infraspinatus can be reattached a bit, if it's a partial tear or something like that, I will also do that. And most probably I will also consider a superior capsular reconstruction.
Johan, any suggestion?
So just to be clear, Paolo, remind us what is the fatty infiltration stage, because it was difficult for us to evaluate it on the MRI. Can you just tell me what is the fatty infiltration stage of each muscle, please?
The fat infiltration stage, most important, is on the supraspinatus and on the superior part of the subscap.
Okay, so basically what we have is a teres, the inferior part of the subscap, which is like the teres minor. It's hypertrophic a little bit already.
Yes,
is that
they are
correct? Yeah.
quite balanced. Yes.
So that means the inferior part of the subscap is well attached. Do you agree with that?
Yes.
Or not?
Yes.
Okay. And probably we have a recent rupture, which is from posterior from superior to posterior, that imbalanced our shoulder to show this pseudoparalytic shoulder today. And the supra and the infra is quite okay. Just the supra is very retracted.
Yes.
It's infiltrated. The infraspinatus is not fatty infiltrated. So for me, I would like to do a repair first. And you asked me what I would do, or what do you?
If you have any other suggestion, any other operation that you can suggest in case like this.
For me,
an acute on chronic, no? Acute.
Yeah. For me, definitely there is a acute rotator cuff tear, but based on a chronic one. The chronic one is the upper part of the subscap, which is gone from a long time. So for this, I don't think you can do anything. It's gone. You cannot repair it. But the supra is probably not repairable, but the infra could be repairable. So I would do, my favorite operation. I would use the biceps to do interposition with a rerouting technique of the supra, and the supra would fix it immediately on the biceps, which act like as a SCR, if you believe in that concept. And then I will reattach the infra, the infraspinatus, so to the bone with anchors, but also to the biceps as an anterior anchorage. So this is what I would do. I would protect the patient in a sprint for a while, and this is what I would like to do.
Okay, I agree about this, and this patient, this is some suggestion about the problem when we have a loss of the subscapularis. That is a really important effect on the function of the shoulder, because you cannot substitute this kind of vector. Regarding the transfer, Ceyhun, a combined pectoralis major and latissimus dorsi transfer for calf deficiency, the combined transfer are not so efficient, so I think that we have to consider what we did. We did this for the first. The first approach was rehabilitation, so self-assisted movements, passive mobilization, and active movement in pool. The patient continued this for 2 months. He came back in this way, with a complete range of motion, The job was still 3+. The path was negative. Still some problem on the subscapularis, no pain, all daily living activities. Of course, you don't have any strength in this shoulder. The strength is poor, but the patient was really satisfied about this.
I have a question.
First of all, consider that if you have something that can change a difficult equilibrium, because in this case we have a shoulder that is really difficult, no? Because the patient has a huge tear for here, and something changing this equilibrium that was so small. What we have to do first? I think that here we have very few possibilities to achieve a good function using an operation, because you have a poor cuff, you have poor tissue, you have poor muscle, and so you do something trying to do your best, of course, but I think that the first option can be the rehabilitation program. Joan?
The only thing that bothers me is when I see a guy as young as you, Paolo, I wouldn't let him with something like that. I would really try my best to try to slow down the natural evolution of the cuff disease in this guy. At 55, really, I would fight a little bit more. Of course, there's that non-operative treatment I would definitely do in a 70-year-old patient, or a little bit less if the patient is quite is not in a well shape. But in a 55-year-old guy, you know, I'm 51, and if you don't want to operate me, I will see another surgeon to be operated, because I feel
the problem was that this patient was in waiting list for the operation.
Yes.
And he came to me back a week first than the operation, telling me I don't want to do an operation because I stay very well. I stay like I was before.
But that's fine. I mean, that's fine.
Yes, but it's so difficult to push the patient towards the operation when the patient is without pain, a full range of motion, and he tell us that he is going in the same way as first in the operation. So difficult.
I agree with you, Paolo.
The comment I would like to highlight the comments of Johan. Yes. It's not really right to do a conservative treatment in this kind of patient, but the problem is because this is a clear evolution. In 10 years, I think that we'll see a patient with the necessity of a reverse cuff, reverse prosthesis. But I think that first of all, try to create to put again the patient in the no pain group, and after this you can evaluate with him.
Completely agree with you. Completely agree.
George, any comment?
Well, if I may, for me personally, it's very interesting to see that the internal rotation is so good now. So previously the patient could not internally rotate. It was at the buttock level, and now he's at T12, which is amazing. But I apologize if I'm repeating myself, but in my opinion, this simply shows that the subscap is really working well. And such a positive job test shows that the biceps is really painful in the absence of a supraspinatus. And I think that having this conflict in the presence of a well-functioning subscapularis might compromise the subscap going down the road. And a biceps anatomy might be, I don't know what you think about this, but it's really interesting to see this. It's amazing.
It's interesting. This patient find again the equilibrium that he has 6 months first. Okay, second case.
Great. Sorry, I have 2 or 3 questions about the chat, from the chat about this case. So would you routinely perform an X-ray at the first imaging step in massive irreparable cuff tear?
Always do X-ray first, then MRI.
You too, Dr. Barth.
We have spoken exactly at the same thing at the same time.
Right.
So, yeah.
So, and how long do you consider an MRI valid? 3 months, 6 months?
For me,
considering
it depends with the type of the size of the
6
tear.
months is a good way.
6 months is a good way. Great. And you consider always an approach, a rehab approach preoperatively?
In this patient where the trauma was not so huge to determine a complete tear, and when there is some sign of a previous tear of the supraspinatus, degenerative tear, I think that the conservative approach is mandatory.
Valentina, that is an excellent question. I don't consider the rehab protocol the first point that we have to do. What I consider is to work exactly what Paolo has said on non-painful shoulder and with the patient who has full range of motion, passive full range of motion. So if there is any stiffness, I never operate on a shoulder, on a stiff shoulder. So this is the point where I use physiotherapy. I don't use physiotherapy in a patient who has full range of motion and an acute rotator cuff tear in a 55-year-old patient, because I think he's young. So in this case, I would like to repair as soon as possible to avoid the progression of fatty infiltration of the muscle. So for me, the rehab protocol is not like an automatic thing. It's just to treat the stiffness. Okay?
Okay, great.
Right.
We can continue with the second case. Thank you.
Let's see the second case. In this case, we have a patient that we can know, that we find every day. This is a female, 54 years old, nurse. She is a smoker, has a painful right shoulder for 2 years. He has a 3 injection with beneficial effects. This is the examination of this patient. This is the X-ray. Edna?
Yes.
Any comment on this X-ray?
I think
quite normal, no?
normal, yes.
Yes, nothing to tell. Maybe there is something on the right side, on the right image, on the posterior tuberosity. There is on the posterior part of the greater tuberosity, there is some sign of maybe calcifying tendinitis, something on the... Can you see, Joan?
Yeah.
Yes, something on the posterior part.
Anthesopathy or something like that. It's not
Yes.
real calcite tendinitis, because when it's the
This is a type D
deposit. Yes, when it's really very next to the bone, very distal, it looks more like an anthesopathy, but not really like the real calcite deposit. Tendinitis.
This was the famous type D of Mollet, no?
Yeah, exactly.
Okay. No, this is wrong. Sorry, this is not emergency room X-ray. This is cuff. Just a moment. It was okay. There is. Can you see the supraspinatus here?
Sure.
The supraspinatus is degenerative, maybe a small tear at the end. The subscap and the infraspinatus are good, even if the infra there is some sign of inflammation. Okay, this is the muscle. What to do in this patient?
First, Edna, can I ask you a question?
Yes,
regarding
please.
the coronal cut?
Yes.
what would be your suspicion? Because you see an hypersignal and you see it's difficult to see the supraspinatus. And what is this hypersignal coming from, to your point? And this is very important to analyze this, Edna. Can you tell us about it? For you, what is the hypersignal we see in the coronal cut? You see it? It's above the tendon. You see above the tendon, you are an
Yes.
hypersignal.
Yes.
And what is it for you?
Some calcification, maybe.
No, maybe it's more, calcite deposit. It looks black because it's hyposignal. It's calcite, but when it's white like this in an hypersignal in the T2 weighted sequences, it's more like water. It might be inflammation. So what would it be for you regarding this if you see this hypersignal above the supraspinatus? It's probably the bursitis. You agree with me?
Yes.
Edna?
Yes.
And if you have a big bursitis like this, what could be the problem with an MRI? There could be a volume effect that will let you think that there is a real true supraspinatus tear, but maybe it's just inflammation. And this is something that you guys must be aware of. When you have a big bursitis, you can overestimate supraspinatus tear. So maybe there is one, but it's very difficult to be sure that you will have a supraspinatus tear. So that's why my preference for rotator cuff evaluation is a arthro MRI, because by this way you can differentiate supraspinatus tear from just inflamed supraspinatus like tendinitis and bursitis. Do you agree with me, Paolo?
Oh, yes, of course. Even if in this case, I think that it's really useful, this MRI, because it's a good, I think, a good quality MRI, but you can see that all the tendon is full of water, of bursitis. So there is the typical sign of when the tendon is not good, brilliant, but the tendon is like an old pullover. No, there is some sign of degeneration in this patient. I think it's interesting to know that there is a good representation of the muscle. No, on the right you can see that the muscle is quite good. Yeah. So, but this was in 2022. Okay, let's check what happened. So this patient was in 2022, and the patient was treated. I tell you, because it's going to be late, with injection and physiotherapy. And the patient was good for a couple of years, and the patient did not make arthroscopy. But in 2005, the patient came back. He was a new acute phase in October 2024. Any response to injection, pain, and pain in the night, even treating with the painkiller, but without any results, any outcome. Forward elevation was under 90 degrees, abduction 90 degrees, external rotation lag sign 2+, and dropout sign 3+. So, what do you think with this examination, George?
Well, the easiest way would at this point be to think that the tear progressed and it's now probably a type D type of tear. But I would like, given the multiple corticosteroid injections, I would like to exclude an infection. She's also a smoker. Yeah.
Which examination? Roberto?
Not sure.
Well, a new MRI. My prime suspect here is a posterior superior cuff rupture, traumatic, over chronic, since we know she already had a sick tendon.
This is the situation after 2 years. Little bit more than 2 years, but after 2 years. Okay. This is the situation. Susanna.
So I know there is lesion, posterior superior lesion. So we have especially what's worrisome is the fat infiltration and the atrophy of the infraspinatus. And she also has a year or less, so probably also teres minor involved. So the subscap seems okay. I mean, the atrophy seems good. And from the central part doesn't have too much lesion. So I would like to know what's the pain to exclude infection, as George said.
Now, patient has all parameters, parameters that are okay for infection.
Okay.
She's a nurse, so she has done all.
So in this case,
even a lot of infiltration in the past.
Yeah, that's why we would like to exclude infection. But I think in this case, we have to distinguish if it's a functional shoulder or non-functional shoulder.
This is a non-functional shoulder.
If it's a non-functional shoulder, then in this case, we do not have the posterior cuff. And so probably the best thing would be to do a transfer to restore the...
Ceyhun, do you have the same idea? You are the fan of the transfer. What do you think? Is the time to do a transfer here?
Maybe. I am not always the fan of the transfers. If it's indicated. But first of all, I try to repair the posterior superior cuff, but I think it's retracted. In this case, muscle transfers should be performed.
Okay. Joan, do you think that repairing infraspinatus when you have an external rotation like sign is useful?
In this case, I think repair has no chance to help this lady, because it's already the fat infiltration of the infra is already stage I would say 4. If you I don't know if you agree, because you saw all the slides.
Yes, it was a 4.
Yes. So you have a stage 4. You have an external lag sign. I think it's unfortunately it's irreparable. For me, it's the definition of an irreparable cuff.
This is the perfect definition of irreparable. In this case, I think that we have to consider this, because the patient conservative treatment is impossible, because the patient has already some injection. Arthroscopic repair, my idea is the same of Joan, of course. When you have an external rotation like sign, when the arm is not able to stay on the side but fall on the belly, I think it's impossible to understand, to try to think to a repair. Maybe a graft augmentation can help us, George. You are the fan of the graft augmentation. Do you think that the superior capsule repair can help us?
Well, I would definitely try to repair the vertical, to provide some vertical stability to this joint. In my opinion, the supraspinatus doesn't look that irreparable. Probably the infraspinatus is much harder to repair in this case. So maybe I think I don't have that much experience with tendon transfers, but I would think that I would attempt a supraspinatus repair with a balloon and a transfer, lower trapezius transfer.
Okay.
But I'm sorry, I'm not sure about her external rotation. I think I lost that part. If she has a complete lag.
Complete lag.
Okay, so I would think about the lower trapezius transfer.
Okay. Susanna, do you agree?
Yes, I would consider also a latissimus dorsi transfer. The only thing that worry a little bit is the fat infiltration of the teres minor to do the latissimus dorsi transfer.
Okay, this is our choice. This was our choice. This is an axillary approach. This is the dissection between the teres major and the latissimus dorsi. I'm not a fan of the lower trapezius. For me, the indication is more about the inferior, the latissimus dorsi. I think that you can see well the latissimus detached. Important to have all the mobility of the latissimus. Usually we do we tubularize the latissimus and we give two stitches on the lateral side. This is just to show you the open part. And this is the scoscopic view. This was the biceps. He survived for a few moments. Sorry, but Joan, I know that you try to maintain all the biceps.
Not in this case.
Not in this case, eh? Just a smoothing with the shaver of the acromion. We can, oh, sorry. And this is the tear. You can see that I think that in cases like this, it's really possible to cover. Now I show you our technique for the latissimus dorsi transfer. We come with the grasper from the anterior part. We pass over the teres minor, and we follow the deltoid. I'm sorry. No, sorry. Going posteriorly to find the gap, the space. In this case, we just go outside and without using any instrumentation, we go anteriorly and we fix with a couple of screws. One for the anterior part and one for the posterior part. This is just to show you the final view of the operation. This is the final part. So the message for this kind of patient is when you don't have, when you miss some function, in this case external rotation, you have to find a way to recover this function. I think that you can be the fan of latissimus dorsi, you can be a fan of lower trapezius, you can be a fan of lower trapezius and something else, but the most important part is to understand that when you miss a function, you should cover this function with a some graft. What do you think, Jean?
Yes, I think this is important thing for you, the young guys. There is the clinical evaluation, the clinical assessment with the external lag sign and everything. This is for you to understand the tear. But what is very important is to understand the problem of the patient. And this is what you need to treat. You don't need to treat the lesion. And the way the approach you have, George, is too much a lesion approach. If you do the lesion approach, you will treat everything. Basically, it's a little bit the American way. But in Europe, we're not like this. We are not going to enter the scope and repair everything we can. We have to understand the problem of the patient, and this is a problematic approach that we have. and that I have learned also from Gilles. And this particular patient, I know that tendon transfer, it's not the best result I can expect. I can expect good result with a repair, but I cannot expect excellent outcomes with a transfer. So this is when I do a transfer, I think there is no other option. So just to tell you, this patient, I will particularly wait as long as I can with a non-op treatment, because we don't care. The fat infiltration is already very important on the infraspinatus muscle. So we don't care to wait. And in this case, I would wait as much as I can with the physiotherapy to try to recover some external rotation. And she has a good teres minor, so we can expect a good external rotation. And most of the time, I can get a positive external rotation. If the patient is able to externally rotate with a positive external rotation, I will not do a tendon transfer. Tendon transfer is for me only for patient who has a negative active external rotation. And for this, I completely agree with Paolo. You can do whatever you want. You can do a lat dorsi, you can do a lower trap, whatever you want. But this is something just to gain a positive or a little bit of external rotation, but you won't have 45 degrees of active external rotation unless you had it before. And in this way, it's just useful. So again, the most important thing is to treat the problem of the patient, but not always the lesions.
Thank you, Joan. I think that we have a lot of messages. Valentina.
Okay, we have one last question because unfortunately we run out of time. So they ask you how much time you wait between an injection and a tendon repair or transfer.
I think that differently from prosthesis, we can even not wait after injection. I think that the risk of an infection after an injection is so low when you do an arthroscopy, because you wash with a lot of fluid. So I think it's different if you have a prosthesis. Usually the knee surgeons wait for 6 months before a knee prosthesis. I think that we can use the same the same deadline for the shoulder, but I think that there is no evidence on the shoulder.
Okay, great. Is the same for you, Dr. Barth?
Yes, I have the same
You
thing.
agree?
I don't care about an injection, cortisone injection, if I have to do a arthroscopic rotator cuff repair, but I do care if I do a prosthesis.
Right. So thank you all. Great cases and great discussion. Dr. Paladini and Dr. Barth, thank you for sharing your expertise with us. We all have learned so much from you. Many thanks to all the participants. Before concluding this session, we would like to encourage you to scan the QR code to apply for future OSES events. We invite you to join the CESEC community and become a junior member. You can scan the QR code as well. The next event will be on updates in shoulder instability, the May 14th. And of course, you can miss next CESEC Congress in Rotterdam. Early registration deadline is June the 1st, and there is a special discount for CESEC members. So see you next time. Bye. Thank you all.